I've been out till 2:45. Would you lock
Okay,
the door?
well, thank you for coming. My name is Edggar Frausto. I'm one of the Geriatric fellows here for the VA. Today I'm just going to be talking about osteoporosis in the elderly, and hopefully I'll be giving you some information. It's still a very debatable on recommendations, but we'll talk about that. So
I had an NIA grant, osteoporosis, 20 years ago.
An expert. Uh-oh. That's what
I forgot.
That's what
Forgot
one
all
fears when
of
doing presentations. Hopefully there's not
I
a...
forgot all of them.
So, definition of osteoporosis is a systemic disease characterized by low bone mass and microarchitectural deterioration of the skeleton, leading to bone fragility and increased risk of fractures. So basically what this means is there's bone formation, and every year there's bone. They take away the old bone and they put new bone back. Throughout our age and as we get older, this mechanism is affected, and it's not as when you were in your 20s. Is osteoporosis important? Is it something that we should battle? Well, in the US, 10 million people have osteoporosis and 34 million people have osteopenia, and we'll be talking about those criteria and the definition and the differences between osteoporosis and osteopenia. There's about 2 million fractures per year. 50% of women and 20% of men will sustain osteoporotic fractures in people over 65 years old. So pretty higher in women, about half of them will develop a fracture. 2.5 million office visits per year also, 400,000 hospital admissions, and about 180,000 nursing home admissions, with a total of $25 billion are the estimated for 2025. Also, there is a study that showed that women over 65 years with a recent hip fracture, 13% of them were receiving adequate treatment for osteoporosis. There is also us. We're not treating properly. So, question, which patient is least likely to have an idiopathic osteoporosis? Is it the slender 21-inch tall 71-year-old Caucasian woman with a T12 vertebral fracture? Is it an 86-year-old Caucasian man with a hip fracture? Is it a 65-year-old thin, alcoholic Caucasian woman who smokes and has a T10 to T12 vertebral fracture? Or D, 67-year-old obese African-American woman with a T4 vertebral fracture?
D.
Exactly. And the way that we would be able to answer this is if we know the risk factors. So risk factors for osteoporosis. The ones on the left are the ones that are really non-modifiable. We really can't do anything about those, but the ones on the right are the ones that we can change and try to prevent for osteoporosis. So the ones on the left are female sex, petite body frame, whether white or Asian, or they go through early menopause, whether they have a fracture in a first-degree relative, and genetic disorders, osteogenesis imperfecta, and such things like that. Things that we can change are on the right side, like low calcium and vitamin D intake, tobacco use, too much caffeine, alcohol use, sedentary lifestyle, nulliparity, and certain drugs like glucocorticoids. Now, what is alcohol use? How does the Osteoporosis Foundation say that it's alcohol use? How much is too much alcohol use? Which is very different than the cardiac one where it says 1 for women and 2 for men. The Osteoporosis Foundation says that alcohol use of 3 drinks or more
A day?
puts you per day.
Oh.
Puts you at an increased risk.
So you're okay, huh?
How much is too much caffeine for the morning after the alcohol?
Really.
Oh, that's a good question. I didn't see any milligrams on that.
Okay.
I tried that and tobacco use, but I guess it's just...
'Cause I think the stuff said this earlier this week that between 3 and 5 cups of coffee actually helps your cardiovascular health. There's some kind of a chemical enzyme or something that's promoted with between 3 and 5 cups of coffee a day.
Yeah.
So I'm
Sounds
good.
In that range, but for
2 glasses of wine, 3 cups of coffee, we're good.
So the prevalence of osteoporosis does increase with age. By the age of 50, 5% will actually meet criteria for osteoporosis. By age 70, that increases to 50% will meet criteria for osteoporosis. And by age 80, 75% will meet criteria for osteoporosis. So as you get older, more than likely will develop osteoporosis. And the average age for a first-time hip fracture is 75 years old. So what this means is we should start early for preventative measures. Now, there's also the rule of 1/4 or 25% that states, following a hip fracture, what are my 4 possible outcomes? And 25% will be institutionalized, that's a nursing home or long-term care. 25% will be home with new functional deficits, meaning they won't be able to ambulate properly, probably using the walker, using the cane, just not going back to their baseline. 25% will have no change in function, and those are the lucky ones that will go back to doing whatever it is that they were doing before, and no problems for them. But this is the other unfortunate one, is that 25% will die within the first year of their hip fracture.
Is that related to embolus or emboli? Or
Multiple factors going into this, but for the most part, the 25% in 1 year. But it is lots of different factors. So how do we diagnose, or how do we check to see if somebody has osteoporosis? With the DEXA scan, of course, which is bone mineral density test. DEXA stands for dual energy X-ray absorptiometry. I don't know if I can pronounce that. So the WHO criteria, which is the World Health Organization, has criteria for osteoporosis that are based only on the DEXA scan. And I'll talk about, right, I mentioned the DEXA scan, and it's gold standard. That's how we check for osteoporosis. The hip DEXA is the best predictor of hip fractures, which is the most clinically relevant site of fractures. The DEXA scan actually measures 2 sites, which is your spine and your hip. There's 3 more common fractures in osteoporosis, which is spine, hip, and your hands. And you fall, you get hands. But the DEXA just checks for the hip and the spine. But the one that gives us a better predictor for hip fractures is the DEXA on the hip. So the way the DEXA scan works is it throws these photon beams on these places of the bones. Each machine is different, so it captures these photon beams and checks the density of the bone. Another way to check for osteoporosis is an ultrasound on the heel. But I put this down because an ultrasound is cheaper, but for some reason it's still just not the gold standard, it's the DEXA. So quantitative ultrasonography is less expensive and more portable than DEXA and does not expose patients to radiation. Quantitative ultrasonography of the calcaneus predicts fractures of the femoral neck, hip, and spine as effectively as the DEXA scan. However, current diagnostic and treatment criteria for osteoporosis rely on the DEXA measurements only. And criteria based on quantitative ultrasonography or a combination of ultrasonography and DEXA have not been defined. So even though the ultrasound is cheaper, more portable, they're still going with the DEXA scan. So this is the criteria of the World Health Organization, which is a T-score. The T-score says that if you're greater than -1 standard deviations, your bone density is normal. If it's -1 to -2.49 of standard deviation, it's low bone mass or osteopenia. Another is the -2.5 standard deviation, which gives you the diagnosis of osteoporosis. But if you have -2.5 standard deviations plus 1 or more fractures, you can establish osteoporosis. So, correction, so if it's between -1 and a 2.49 with already a fracture, you can say it's osteoporosis. Now, these are standard deviations. So where there's a standard deviation, it means it's a standard deviation from the mean, which means that there is a bell-shaped curve. Now, where did they get this information for the bell-shaped curve? Is they actually did, they compared all in a big study, not a study, but in order to get this bell-shaped curve, they got females between 20 and 29 years old to get these normal levels. Also, there is a Z-score that is used, but this one is mostly used to diagnose children, men, and women less than 50 years old. So the DEXA scan is for women that are over 50 years old. Now, who gets a DEXA scan? There's different organizations out there, and each one wants to give their recommendations that sometimes not correlate with other ones. There's the United States Preventative Services Task Force, there's the National Osteoporosis Foundation, and there's also the International Society of Clinical Densitometry. Don't know how to pronounce that. There's also other organizations. There's the Endocrinology, American Academy of Endocrinologists. There's the Society of Menopause that also gives different recommendations. These are the three that I will mention on this one, but going to focus more on the U.S. Preventative Task Force. So who gets a DEXA scan? It's women aged 65 years or older. They both agree on that. There's women aged 50 to 64 with some of the risk factors that we talked about. And this is where they don't agree on. Men aged greater than 70 years old, the U.S. Preventative Task Force says, we looked at the data, that there is, we just cannot recommend for men to get it. But the National Osteoporosis Foundation does. And even men aged 50 to 69 who have some risk factors, the U.S. Preventative Task Force still says, no, we don't have to do a DEXA scan on them. So they kind of omit men. Not sure why, but it's just all based on the clinical information that they have and all the studies. Another way to assess would be the Frausto risk assessment. It's actually a website. You put in all this information, you put in age, sex, weight, height, everything that they ask you for, and it actually gives you a 10-year risk of possible fracture. So, which woman has the highest risk for hip fracture? Is it the 80-year-old female with a T-score of negative 2.5? Is it the 65-year-old female with a T-score of negative 2.7? A 45-year-old female with a T-score of negative 2.7? Or do they all three of them have the same risk?
All the same.
Yeah, like we talked about, this is a progressive problem with age. So the answer would be the 80-year-old female with a T-score of negative 2.7. Now, since most of our people are above 65 years old, we always have to deal with Medicare. So which one does Medicare cover for the DEXA scan? So they'll cover initial screening at 65 or older, and a repeat every 2 years. If treatment is started with a bisphosphonate, they can repeat to see the effectiveness of the treatment after 1 year. And repeated DEXA measurements are cost-effective, remains controversial, and that's why Medicare says, well, we'll just do the first one and then 2 years after that. So also other things that we have to screen for when we're thinking about osteoporosis is we'll do a regular CBC with albumin, total protein, alkaline phosphatase, checking for any cancers, serum creatinine, of course, calcium, phosphorus, trying to check for hypothyroidism, hyperparathyroidism, hypogonadism in men by checking testosterone, and of course, vitamin D. So these are other ways that we can look at it, trying to find the causes for osteoporosis. So another question, so which one of the following is the best test for vitamin D deficiency? C is the correct answer for serum 25 hydroxyvitamin D level is the most abundant one that's in our body. It gets converted to the active form of 125 dihydroxyvitamin D level, but the one that we want to check is the one that's most abundant, which is C. Now, prevention and treatment, like I said, since it could start around 50 years of age, that there's 5% of them can meet criteria for osteoporosis. We want to start early. Everyone should be counseled about weight-bearing exercises, calcium and vitamin D, what is their intake on calcium, what is their diet, smoking cessation, of course, avoiding excess alcohol intake, which is 3 drinks per day, greater than 3 drinks per day, and fall preventions if they have any gait abnormalities. So who will need treatment? Of course, postmenopausal women and men greater than 50 years old that have already a hip fracture or vertebral fracture. Now, vertebral fractures, they're talking about the ones that are associated with osteoporosis, and those are the ones that are under most stress, which is T10 to T12. A prior fracture and low bone mass, a T-score less than 2.5, and second causes have already been ruled out, and a T-score of -1 to -2.5 or at high risk. Also, we can also check with the FRAX, which is a 10-year probability of greater than 3% for hip fracture, or 20% for any osteoporotic fracture by the FRAX index score, which is a website that you can go to. Just type in FRAX on Google, it'll take you straight there. So, these next two slides are the ones that are a little bit confusing because they're just not all getting together and agreeing. So the U.S. Preventive Task Force recommends against daily supplementation of vitamin D3, 400 units, international units or less, and calcium 1,000 milligrams or less. Concludes that evidence is insufficient to assess benefits and harms of higher doses. And guidelines do not address vitamin D and calcium supplements for women or men with established osteoporosis. And this comes from before when the U.S. Preventive Task Force recommended calcium of 1,200 milligrams and vitamin D 800 international units. But they do say that vitamin D supplementation can reduce the risk of fractures at a dose of greater than 800 international units. So this is where it gets confusion, is how can you recommend vitamin D, but then for osteoporosis, you can't say not anything less than 400 or not have an actual dosage or recommendations. But the U.S. Preventive Task Force, if you go to the website, it says it's still viewing all of the studies, and then recommendations should be coming out soon, but they don't give an exact date. So no clear benefit or harm in cancer cardiovascular risk. Nearly all studies of osteoporosis that included bisphosphonate treatments also included vitamin D and calcium supplementation. So if the studies included all of those, why can't the United States Preventive Task Force also include recommendations for calcium and vitamin D? But hopefully they'll give us better information. And the National Osteoporosis Foundation still recommends calcium and vitamin D supplementation of 1,200 milligrams of calcium and 800 to 1,000 vitamin D3 for all postmenopausal women. So which one of the following has been shown to reduce the risk of hip fractures? The actual only one that has been shown to reduce the risk of hip fracture is elandronate from these possibilities. So these are the FDA-approved treatments for postmenopausal osteoporotic women. There's the anti-resorptive agents that lower risk for spine, hip, and non-vertebral fractures, which is elandronate, risindronate, reclast, which is IV only, and Prolia. There's also the anti-resorptive agents that lower risk for spine fractures but show no evidence for effective on risk for hip or non-vertebral fractures, and that is calcitonin, Boniva, and Edista. And then there's anabolic agent that lowers risk for spine and non-vertebral fractures, and that's Forteo or Forteo. So general rules of bisphosphonates, those are the most common ones that we always start on osteoporosis. You always give on an empty stomach and with a full glass of water 30 minutes before any meal. Contraindications for bisphosphonates are esophageal strictures, achalasia, patient unable to stand or sit upright, and if you can't use an oral bisphosphonate because they can't stand or sit upright, then you can use an IV bisphosphonate, which is zoledronic acid, which is reclassed. Also renal failure with a creatinine clearance of less than 35, and also hypocalcemia. Now, if these are contraindicated for bisphosphonates, Prolia may be considered. This one binds to receptor activator, the RANKL, and inhibits osteoclast formation. So, common side effects for bisphosphonates, this is GI upset, headache, bone pain, flu-like symptoms when you use IV administration, esophagitis and esophageal ulcers, perforations, erosions, and strictures, which is why we always ask for them to be able to be standing or sit upright when they take their bisphosphonate. Now, there's an association also with osteonecrosis of the jaw, which is the one that we're more worrisome about. It's actually very low incidence. It's most common with IV bisphosphonates, and also when you do the IV bisphosphonates with cancer patients. What you let them know is just maintain good oral hygiene and a regular dental checkup. Also, there's an FDA alert that bisphosphonates may cause some bone pain, which is severe, sometimes incapacitating, may occur days, months, or years after beginning of bisphosphonates, and the incidence and risk is just unknown. You're not sure why it causes this, but sometimes it does, and it may be relieved after discontinuation of the medication. Also, there's been an association between bisphosphonates and atrial fibrillation, which the FDA did a safety rule, and they found no clear association. They looked at 19,687 patients, and they found that about 2 events in most studies, but they still didn't find a clear association. Now, long-term use and linked to atypical fractures. So the types of fractures is low energy, subtrochanteric femoral, and pelvic insufficiency. Fractures, they also have poor healing, and you can consider stopping bisphosphonates after 3 to 5 years. But there is a trial called the FLEX trial, which had 1,100 women on alendronate therapy, and they averaged 5 years. There was randomized to continue for 5 more years or stop. So between these 1,100 women, they continued for the 10 years, but after 5 years, they randomly picked which ones were going to stop and just give placebo. So there is a clinical vertebral fracture, which risk is lower for continued treatment, especially in 2 groups. Those without pre-existing fractures and a T-score of less than 2.5, or pre-existing fractures and a T-score of less than 2.0, with a number needed to treat between 21 and 17. So those are pretty good numbers to treat. No data for non-vertebral fractures. So this is just for compression fractures. It's not talking about hip fractures. So in conclusion, since this might sound a little bit new to some of us, women who discontinued alendronate after 5 years showed a moderate decline in bone mineral density and a gradual rise in biochemical markers, but no higher fracture risk other than for clinical vertebral fractures compared with those who continued alendronate. These results suggest that for many women, discontinuation of alendronate for up to 5 years does not appear to significantly increase fracture risk. However, women at very high risk for clinical vertebral fractures may benefit by continuing beyond 5 years. So, if they have multiple fractures in the spine, you might want to continue after 5 years. So, which osteoporosis therapy has an analgesic effect in the setting of an acute vertebral fracture? And yes, the correct answer is calcitonin. So calcitonin is a polypeptide hormone. It's intranasal formation for vertebral fracture, complicated by pain for analgesic benefit. It has weak anti-fracture efficacy though. And remember to prescribe calcium and vitamin D even when you start on calcitonin. An increased risk of cancer with long-term use is still questionable. They're still looking at it, and you have to limit this to about 6 months duration. Raloxifene, which is a selective estrogen receptor modulator. This is estrogen agonist antagonist, reduces risk of breast cancer, does not stimulate endometrium, helps with some hot flashing, and has not been shown to reduce hip fracture risk, and these are less potent than bisphosphonates. Another one is the parathyroid hormone. These are daily sub-Q injections, are reserved for patients with high risk for fractures, multiple fractures, extremely low bone mineral density, less than -3, and intolerant, unresponsive to other treatments. There is a black box warning by the FDA for osteosarcoma, so safety should be questioned whether you want to continue more than 2 years. And consider bisphosphonate after 2 years. And the last one, which is Prolia, which is a monoclonal antibody against the RANKL receptor that stimulates osteoclast activity. This one has been shown to reduce vertebral, hip, and non-vertebral fractures. No long-term safety data yet on Prolia. It's not even a generic brand yet. But it's 1 to 2% causes severe hypercalcemia. 6-month injections, and Prolia is one of the most expensive ones that's out there for osteoporosis. And still the role of when you would want to do Prolia as opposed to other ones is still uncertain. So lots of information. Any questions? No kudos questions. I get them all wrong.
In the study where they discontinued the bisphosphonate, did they see an effect on osteoporosis of the jaw? Like, did that prevent that from happening, or is it not a significant problem in the population?
Yeah, that's a good question. I didn't see any other related outcomes or increase in side effects after 10 years of using the bisphosphonates for greater than 5 years. Again, the osteoporosis of the jaw is low incidence, most commonly seen with the IV bisphosphonates. But I didn't see any more severe outcomes or increase in side effects greater than 5 years.
Any questions? Any questions? Funny bone questions? Anything? No? Okay, well, thank you very much. Be sure to sign in so I can send you a evaluation for today, and so you can receive credit for today's attendance.
Oh, I should have asked the pharmacist if my stuff was accurate or if you saw anything else different.
Yeah, so there's also another study that looked at the long-term outcome
It was from the
of
questions
phosphate.
and observations.
So they can be an additional 5 years for those who are less than negative 2.5. Yeah, I'm gonna just go right to What's it? We're gonna actually target patients in our.
You want to sit down the hall? Okay, that might be a good idea.
I would say use Prolia, like if they're questions.
By design?
Oh, she's not.
Get older, losing my head. Many years from now,
Or maybe you can just send her
will you still be sending me a Valentine?
Send her.
send her a note with that calendar. And I don't think you've ever sent to her directly, have you?
Till 2:45, would you lock the door?
Bone is living tissue. Bone building is far from complete when a baby is born. During growth, from infancy to adulthood, bone is increased in size, strength, and hardness. Also, in different parts of the body, bones grow at different rates. Bone growth is partly in response to stresses that are put on the bone by weight-bearing motion. The simple acts of walking, running, jumping, and lifting heavy objects put strain on bones that results in increased bone density. Trabecular bone is found in the shaft and at the ends of the long bones, inside the spinal vertebrae, and inside the flat bones of the pelvis. In the ends, trabecular bone completely fills the cavity, and its structure transmits stress forces to the shaft. Trabecular bone forms an internal scaffolding network for bone. The trusses and arches found within the trabecular bone provide for the great strength of bone and yet surprising lightness. The arches and trusses inside trabecular bone provide a sponge-like appearance in the bone and also create the opportunity for blood vessels to penetrate the bone structure from the center core, marrow, of the long bone. Bone remodeling is such a thorough process that one's entire bone structure is replaced approximately every 10 years. Once maturity is reached, about age 30, the process of remodeling slows, and the loss of bone calcium deposits exceeds the replacement of the bone structure. Beyond this point, it is no longer possible to substantially increase bone density. Over time, the density of the arches and trusses diminishes, and the spaces between them become larger. This process leads to a general weakening of the bone structure. It is a very gradual process and requires decades before any noticeable bone weakness appears. Osteoporosis is the end result of the erosion of the arches and trusses. Osteoporotic bone has much larger spaces between the arches and trusses and is significantly weaker than normal bone. Therefore, it is more prone to fracture. This condition is responsible for many injuries related to falls in elderly people. Women are more susceptible to osteoporosis than men. This is probably related to hormonal influence on bone growth and calcification. Also, dietary intake of calcium and other nutrients, including protein, phosphorus, vitamin A, vitamin D, vitamin K, magnesium, zinc, and copper will influence bone density, in that deficiencies will cause decreases. Finally, genetics have an influence on bone density. Here is the progress of bone loss in a person who has taken some precautions related to osteoporosis onset. Note that as the aging process continues, the rate of erosion of the trabecular structure has slowed, and the end result at age 70 is bone that is stronger and denser than a bone with severe osteoporosis. Strategies for preventing osteoporosis are different for young women and older women. Young women should be sure to meet their needs for calcium, vitamin D, and other nutrients. Physical activity of a weight-bearing nature is also important to maintain bone mass. In postmenopausal women, estrogens, estrogen receptor modulators, and calcitonin can slow bone turnover by binding to bone receptors. Calcium supplementation and regular exercise, especially weight-bearing and resistance activities, are important strategies for older people. Finally, since both tobacco smoking and alcohol consumption have negative effects on bone growth, these behaviors should be avoided for healthy bones. In summary, osteoporosis, the weakening of bones due to loss of calcium and phosphorus from the interior of the bone architecture, is a degenerative disease that is influenced by many contributing factors. Health-promoting interventions such as adequate nutrition and physical activity, and medical interventions such as prescription medications designed to limit progress of osteoporosis, coupled with positive behaviors such as not smoking or using alcohol excessively, can forestall the onset and severity of osteoporosis. Men are also at risk for developing osteoporosis. For men, similar prevention strategies apply. These include adequate calcium, vitamin D, and other nutrients, physical activity of a weight-bearing nature, and avoidance of behaviors like smoking and excessive alcohol consumption.